Great. Thank you. Assalamu alaikum, my brothers and sisters. It's a pleasure to be with you here today. Second. There we go. And to see so many familiar faces again. To those who I haven't met, I'm Ayaz Kurji. I'm a psychiatrist. I run a psychiatry on-call service for primary care at family health teams and community health centers in Ontario, where we provide unlimited support via e-consults, phone consults, direct traditional consults with patients, joint appointments with no wait list, Monday to Friday, 9 to 5. If you're interested in knowing more, get in touch. We may be able to take on another center in January. My email is here. As part of that service, we do teaching workshops for primary care on a variety of different topics like de-escalation, working with suicidal patients, therapy training, psychopharmacology, and in particular, we do a 2 hour workshop on antidepressant selection and another 2 hour workshop on antidepressant augmentation, and then another one on titration and side effect management. So today we have 1 hour, and I'm not going to try to squeeze everything into 1 hour. We won't be comprehensive, but we're also welcoming a variety of different health professionals and others with differing levels of psychopharmacologic knowledge in the room today. So you'll see the formal objectives shortly, but my goal is that whether your knowledge is basic level or advanced, you will all take away a few practical pearls that will enhance your practice in some way or another. And I know we have a couple of psychiatrists in the room as well, and it would really elevate this hour if you contribute your knowledge and your experience through the discussions we'll have as well. So please feel comfortable to do so, and jump in at any point, everybody. So there's going to be the way we're going to appeal to the wide variety of skill sets in this room is by formatting this hour as a massive Kahoot game. So there will be some questions that are more basic, and there are some that will be much more advanced. And we will get each of these questions, we'll use each of these questions as a springboard for further discussion around each subtopic. So you get a little taste of everything and walk away with some pearls. We'll allow ourselves to go off on some tangents. So if you have questions at any time or any comments, bring them up. We're not going to get through every question on the Kahoot, and that's okay. That's by design. What's important is that this next hour is productive and helpful for you and your patients. Next slide. Let's see. There we go. Okay, so disclosures, I am receiving an honorarium with the exception, like the other speakers, with the exception of some paid surveys I don't receive and have never received any payment from the pharmaceutical industry. I have no financial or other disclosures of relevance. We will be discussing some common off-label uses of medications. And also this is intended for educational purposes. This is not intended as specific medical advice for any of your patients. I'm responsible for making sure the information I provide to you is accurate, and you're responsible for applying this to your patients. Okay, so while we test our reflexes with quiz questions, you'll get pearl after pearl thrown at you around antidepressant selection, managing common side effects. We'll touch on a few augmentation strategies as well, focusing not just on depression, but other diagnoses as well. And take as many notes as you like. But I've also created handouts for you on many of these topics. So, for example, like managing antidepressant-induced nausea or sexual side effects or prescribing lithium as an augmenting agent. So, depending on the direction that our discussion goes today, I'll compile the relevant clinician handouts and I can email them to you. So just send me a brief message. My email address is there again at the bottom. Just send me a brief message with the word handouts or something in the title, and I'll send them your way after the session. So I can gear this session in a way that's most useful. I just want to get a quick sense of who's in the room. So can you put up your hand if you're a family doctor? Okay, and if you're a nurse practitioner? If you're a psychiatrist? All right. And if you are a student? If you're a social worker? If you're a nurse? If you're a therapist? Okay, if you're a faith leader, researcher, psychologist, other mental health professional, other allied health, or no? Okay, anyone I missed? Does as a non-clinician? No. Okay. All right. So, um, okay. So that's helpful. We're okay. So as a little exercise, I'd like you to take out a piece of paper, or your computer if you want, but and take 45 seconds to just write down as many medications you can think of from each of these classes. So these are the different antidepressant classes. And I suggest you leave a lot of space in between the medication names that you write down, since today you're going to hear a lot of pearls and a lot of information about different medications here and there and all over the place. So if you want to take notes, then you would need this paper and help organize yourself accordingly. So SSRIs are selective serotonin reuptake inhibitors. SNRIs are serotonin and norepinephrine reuptake inhibitors. Then we have noradrenergic and specific serotonergic antidepressants, norepinephrine and dopamine reuptake inhibitors, serotonin modulators and stimulators, serotonin receptor antagonist and reuptake inhibitors, tricyclic antidepressants, irreversible monoamine oxidase inhibitors, and reversible inhibitors of monoamine oxidase A. All right, so that might be enough time, maybe not, but here are the answers. And So the ones that are in green is just my own personal opinion of what's probably most important for family doctors, nurse practitioners to be aware of, uh, uh, and to be really comfortable with. Psychiatrists in the room, feel free to disagree with me here. It's my own personal opinion. Maybe vortioxetine should be on the list too. I don't know. But there are other medications with antidepressant properties too that are not on this list. Anyone can think of any? Yeah, that's right. So antipsychotics, there's five antipsychotics actually that have efficacy for bipolar depression. That's quetiapine, olanzapine, fluoxetine combination, lurasidone, cariprazine, and lumateperone. Lumateperone's not available here. And then there's antipsychotics that can be used for augmentation purposes. So aripiprazole, brexpiprazole are two of the first line augmentation agents for depression. Any others? Any other antidepressant properties? Yeah, that's right. Lithium has antidepressant properties as well, and it's not on this list here. There's also dextromethorphan bupropion combination or Auvelity. There's ketamine IV, ketamine intranasal, lamotrigine as well. Okay. And ECT, definitely ECT, RTMS, repetitive transcranial magnetic stimulation, lifestyle interventions, right? So um, this is not a comprehensive list. Okay, so when we're selecting antidepressants, so many of these questions will be about how to choose the right antidepressant. And when we're selecting antidepressants, there's so many different things that we need to take into consideration. You can just shout it out if there's one consideration that. So, for example, the first one, I'll give you the first one, and that's patient preference. Any other thoughts about side effect profile? That's right. Yeah. So and money is another one, right? Um, so side effect profile. So, for example, some, of course, have more likelihood of side effects than others, and those can actually be leveraged. So, for example, mirtazapine is more likely to cause weight gain, more likely to cause sedation. So, for someone who's not sleeping, not eating, right, mirtazapine might be a good choice. Cost, right? So, some are available under ODB, some are not, and some are very expensive, especially some of the newer ones. We need to keep that in mind as well. Any other considerations? Patient medical history, and not just psychiatric history, medical comorbidities, right? Like as one example, let's say there's like a significant liver dysfunction, right? So, there's some antidepressants that are safer in those situations, like desvenlafaxine, escitalopram, citalopram. Some that you might want to avoid, like duloxetine. I think someone else raised their hand. Pregnancy, yes, that's right. So some that may be less, you may want to go away from like paroxetine. Sertraline is one that has the most evidence of safety, but generally speaking, whatever has made them well and kept them well is something that we want to continue them on, and we'll talk more about this pregnancy later. Age, yes. So for example, for adolescents, right? Like generally speaking, if someone has depression and needs an antidepressant and they're an adolescent, fluoxetine is usually the first line. If it's an anxiety disorder, sertraline is often the first line, right? Let's say there's some more recent evidence for perimenopausal women that maybe SNRIs might be possibly more effective. Any other thoughts? Acuity of the depressive disorder, right? Like if this is someone with acute intense suicidal ideation, well, maybe you want to think about things like ECT, for example, ketamine, right? And if you can wait a little bit, antidepressants do take a while to several weeks to start having its full effect. Exactly true. Yes. Yeah. If it's a mild form, for those who didn't hear, especially if it's adolescent, mild form, you may not need to start an antidepressant, right? You start with other approaches, psychotherapy, lifestyle interventions, etc. That's right. So I heard family history, so family history of response, perhaps, to medication, and yeah, comorbidities, yeah. So medical and also psychiatric comorbidities too, right? So if, for example, the person has depression and PTSD features, well, then you might not want to choose citalopram, which has all negative evidence in post-traumatic stress disorder, right? If uh, there's clinician preference, so the clinician needs to be comfortable with the medication that you're going with. So hopefully this helps to increase your comfort level with different, so that it expands your toolbox. Yeah. Exactly. So for those who didn't hear, compliance to treatment or likely compliance to treatment of the patient. Let's say something like, someone who's willing to take it but is just very forgetful. Well, then maybe fluoxetine might be a better choice because it's got a really long half-life, right? So it's actually not a big deal if you miss a couple of fluoxetine meds. But if you miss a venlafaxine or a paroxetine, well, you're probably going to get some withdrawal effects, and it won't be that pretty. Yeah. All right, yeah, great. So I'm just going to see if we missed any. So response and tolerability to past medication. So for example, if someone had nausea on escitalopram, well, you don't want to switch them to sertraline, or venlafaxine, which has a higher risk of nausea, for example. Age, we talked about patient-specific symptoms, side effect profiles, mental health diagnoses, medical comorbidities, pregnancy, lactation, medication tolerability, drug-drug interactions is another one, right? Adherence, availability as well, and cost. All right, excellent. So we're going to also be talking a bit today about augmentation strategies or adjunctive strategies, which they're more recently called in the CanMed guidelines. So when would we switch and when would we augment? This is actually a very common question that I get working with primary care. Not always completely sure what's the right thing to do, and it's not always completely straightforward. But what would be a situation when you would switch or when you would augment? How would you make that decision? Yeah, so if the side effects are bad, then you would be more likely to switch. Yes. So patient tolerability, right? Like if the patient has side effects to it, well, there's different ways to manage it, and maybe the best way to manage it is just abandoning ship and trying something else, right? Yeah. The costs. Yeah. So unfortunately, that is a consideration for many patients. Yeah. Worsening in symptoms. So if the symptoms are worsening, would that make you more likely to switch or augment? To switch? Okay. So generally speaking, you know what? I think you can make an argument in different clinical situations for either. I think so. Generally speaking, one would switch when there's been no response to the antidepressant, right? Or when there has been actually, and then when there has been some response to the antidepressant, but not enough, right? We often don't want to abandon ship completely and lose the gains that we've made, and that's a situation when we would augment. And more recent evidence has shown that really actually switching strategies after the first switch, beyond that, it's much less likely to be effective, and much more likely to be effective if one augments. The other reason is when there's significant side effects with the antidepressant, as was mentioned, right? Like if significant side effects, you might want to switch. If you want to alleviate a specific side effect, sometimes you actually augment, with the purpose of the augmentation agent actually targeting that specific side effect. So that can also be something that one considers. Okay, so other than medications, there are some other things one could augment with. Okay, I gave away the first one. Psychotherapy, so cognitive behavioral therapy, interpersonal therapy, behavioral activation, those are the first line interventions as per the CanMed guidelines. Anything else? I heard ECT earlier. Anything else? Yes, so there's natural remedies. So there are some that have more evidence than others. So for example, L-methylfolate is now gathering some more evidence, especially for those who have elevated inflammatory markers and who have high BMI. Omega-3 are both in the CanMed guidelines. Any other? Yeah, treating the comorbid. Yeah, so I mean, if they're medically unwell or like if they're in a lot of pain, for example, definitely, right? Alleviating that will help with the depression as well. Yeah, so can that's an interesting one, cannabinoid products. So the current evidence base does not support the use of cannabinoid products for the use for specifically for depression. It's The level of evidence is not nearly the level that we have for other recommendations. And in fact, especially the THC component could potentially make things worse, especially if you have an anxiety disorder. But they are used for other indications, and there is definitely a lot of controversy in this field. And it is something that a lot of people do use. Any other thoughts? Mhm. Right. Yeah. So good question. I'll elaborate a bit further. So there's many different components of cannabis, right? But the two main ones are THC and CBD. THC, there is evidence of harm. And in particular, it's more likely to result in causing psychosis. And CBD, actually, there is some weak evidence of benefit. But when one actually goes and purchases cannabis, even if you get a CBD product, there often is a good amount of THC in there as well. So one needs to look at that specifically. But the level of evidence for CBD is not enough evidence for us to recommend this is for a second, third line. But there is some promise there potentially. Yeah. And for the short term, people do find that THC products do help them with alleviating anxieties in the very short term, but in the long term has actually been shown to often increase anxiety. Yeah. Any other thoughts? Yeah. So the comment was on lifestyle, right? And definitely. So in particular, what's mentioned in the CanMet guidelines is exercise. In fact, the more recent release of it emphasize exercise even more. So for mild depression, it's a first line intervention, similar evidence based to medications. And for moderate depression, it's considered a second line adjunctive agent. So exercise is a big one. And then other lifestyle changes like sleep hygiene, CBTI, as we heard, dietary changes, smoking cessation, all have evidence. Yeah, great. Okay, so yeah, yeah. So the question was on music therapy, art therapy, and And nature therapy. So I am aware of some evidence for nature therapy, positive evidence that does support, and as well as for art therapy, especially if there's a PTSD component. I am not aware of any evidence around music therapy. Maybe the other psychiatrists or other people are aware, but it hasn't reached the level of evidence to be recommended in say, the CanMed guidelines, for example. So there's other therapies that have much more evidence and would be more evidence-based. Yeah. Yeah. Okay. So lifestyle changes, exercise, many different types of exercise, light therapy. So this involves having a light lamp. And now the light lamp that you need specifically is one that has 10,000 lux, and you use it for 30 minutes in your close peripheral vision. So 30 minutes every morning, which is hard to do actually, but it has been shown to be effective to be used in monotherapy as well as an adjunct. And then acupuncture, digital health technologies, all of these have some evidence. And repetitive transcranial magnetic stimulation is a big one, and ECT. All right, so we are going to soon start the Kahoot game in about a minute or two, but I just wanted to show you, maybe 3 minutes, but I just wanted to show you this slide here from the CanMet guidelines, because this is, we're going to also be talking about adjunctive agents. And I wanted to show that, there have been some changes since the 2016 guidelines. So those with the stars have been changed. So, brexpiprazole has come up from second line to first line. IV and intranasal ketamine has moved from experimental to second line. Quetiapine and risperidone, they've been downgraded to second line, not because of efficacy, but because of side effects. Cariprazine is new, and so are lamotrigine and pramipexole under third line treatments. So keep in mind that in order to be making a first line recommendation, level one evidence from RCTs are needed, and we may not have sufficient RCTs in the case of, say, older medications like lithium, for example, or in the case of newer medications like cariprazine, right? So hence that might be the part of the reason why they may not be first line. Other medications in the second line list are here because of side effects like olanzapine, risperidone, quetiapine, right? Because their metabolic impacts are much more, typically much more significant than aripiprazole and brexpiprazole. The other thing I should just mention here is that unlike other guidelines you see, um, in this specific guideline, it's actually very reasonable and appropriate to skip over the first line options and start with the second line option, right? Depending on the clinical scenario. So while the first two, do have the most evidence of efficacy, sometimes there's good reasons to actually choose one of the other options too, and we'll go over that in some of the questions today. So there's no clear algorithm all the time, and sometimes there's more than one reasonable answer. And then additionally, these are just for major depressive disorder. This is an example of, so this is a extract from the Canadian Anxiety or the Canadian Clinical Practice Guidelines for the Management of Anxiety, PTSD, OCD. And I know it's 2014, which is quite some time ago. I heard that they are coming out with a new one soon. And since then, there has actually been quite a lot of new changes that have been made. But this is still a very helpful guide. So, for example, if someone has symptoms of, say, PTSD and social anxiety disorder and OCD, right? Then ideally, the medication that you choose is something that's first line for all three of them. So you can consult this when making your medication decision. And if you want a copy of it, you can just email me. I can send you a copy of the guideline as well. So just a couple of little pearls here. There's two medications that's first line for everything here, and that's anyone know what those are? Okay. I heard escitalopram. That's almost correct. Escitalopram is missing from PTSD first line, but it is first line for everything else. And interestingly, citalopram, as I mentioned, was not recommended, has got negative evidence, many negative RCTs for PTSD. And escitalopram is actually, so citalopram is made up of two enantiomers or mirror images of each other, R-citalopram and S-citalopram. And escitalopram is just that aspect of citalopram. So, considering that citalopram is negative evidence, escitalopram may not necessarily be your first go-to for PTSD, but it is first line for everything else. Anyone know what's first line for everything? Sertraline, yeah, and paroxetine, but ask most psychiatrists in the room, and we'll tell you how much we hate it. So it's paroxetine has comes along with many side effects, and it's not usually well tolerated, even though it can be effective. Um, yeah, so this is and then so since then there have been other developments in the field, like for example the use of silexin for which is the lavender for generalized anxiety disorder. There's been, propranolol is not recommended here, but further evidence has been developed since then that propranolol can be useful, especially if you have more of a somatic component. Let's say if there's say OCD, right? Memantine to pyramid mentioned here. PTSD. So there's no mention of prazosin here. There's no mention of doxazosin. No mention of clonidine, right? And as we know, these can actually be quite useful if there's PTSD-related nightmares, for example, or hypervigilance and there's no mention of neuromeds like vilazodone, but it's still a useful reference. Okay, all right. So now we're going to go on to case scenarios. Can we switch over to the Kahoot? So for those of you who have not done played Kahoot before, you get points based upon, of course, if you get the answer correct, but also based on how fast you answer. So what I'd encourage everyone to do is to take out your phone. You can take out your computer and you can go to kahoot.it. So it's kahoot.it. Or if you have a Kahoot app, you can just put it into the app and you can put in the game pin, which is at the top. So 9767030. And hopefully those who are joining from virtually can also join. So I'll just repeat the game pin for those online. It's 9767030. You can put whatever name you want, but if you win, then you must reveal who you are. You can also use that QR code if it's easier, although it's half hidden now. Okay, and the way we'll do this, just a reminder, is if there's any questions that come up, just we're using each of these questions as a springboard for further discussion. So um, don't feel like you need to wait. Great. Okay, I'm going to give maybe like 5 more seconds for people to join, and then we're going to begin. Yeah, some of these pictures are very creative. There we go. Okay, we've got about 32, 33 people on. Okay, great. Okay. So someone dropped off. All right. Sorry for the person who dropped off. I'm going to start. Okay, there we go. It'll work. Okay, it's not working for me to press this. Maybe you can press start. And thanks. Great, thanks. All right. So as I mentioned, there's a mix of questions here. Some easier, some much more difficult. Okay, 16-year-old male with major depressive disorder who cannot swallow pills. Which one would you choose? Great, nice work. So fluoxetine comes as a liquid form, right? So when you can prescribe that. Other things to keep in mind is that escitalopram come as small pills, right, as well as vortioxetine. And sertraline, the capsule can be opened and dissolved in juice, and can also be compounded into liquid. Don't tell the people who made the monograph that it can be opened and dissolved into juice because they'll disagree. But and for people who can't swallow pills, there are some videos I have. I can send those to you as well. If you YouTube Bonnie Kaplan, that's a great can give some great coaching. Really helpful for my kids to teach them. Gradual exposure with Tic Tacs and M&Ms. So I did that with my kids with M&Ms. I figured just to teach them how to swallow pills before they have to. So. And then there's like a pill swallowing cup that can also help some people as well. Mixing it with thick apple sauce or thick yogurt or ice cream or applesauce can help as well. Okay, all right, great. Next one. Okay. Um, 73-year-old female, depression, breast cancer on tamoxifen, has weight loss, anorexia, nausea, insomnia. What would you avoid? And there's multiple correct answers here. All right. So all of the ones with the check marks are things that you must avoid in this person. And the reason why is because tamoxifen gets converted to endoxifen using in the liver with CYP2D6. And all of these medications can inhibit CYP2D6. Sertraline and duloxetine can do it when they're at higher doses. And bupropion, fluoxetine, paroxetine can do it at low doses as well and can be pretty potent. So if you do that, what happens is then the tamoxifen does not you can impact the endoxifen, and then it won't work, and the breast cancer can return. So venlafaxine would be a safe option here. But what would be the best option for someone like this, probably, and which is not listed here? Anyone have a thought? Well, keeping in mind what the person has: weight loss, anorexia, nausea, insomnia. So sertraline low dose would be okay. But then you might be limited by how far up you can go. I heard mirtazapine. Yeah, mirtazapine. Yeah, excellent. Yeah, and oh, I don't know what happened here, but um, okay, there we go. Yeah, so mirtazapine is a great choice because you're leveraging the side effects, right? So not only does mirtazapine help to increase your appetite and help you sleep, but it also has antiemetic properties as well. So it's actually a really good choice for people who have cancer or who are in palliative care, for example. Okay, all right, next one. All right. 27-year-old Muslim female, major depressive disorder, does not want to take medications that may contain gelatin. Which antidepressants would you avoid? All right, so you're all right. Good job. All of these come in capsules that have gelatin, and it's 85% of the time it's like pork gelatin. You can, of course, ask for it to be compounded. You can ask for the vegetarian capsules. And depending on the pharmaceutical company, sometimes there is some differences between ones. But if you want to be safe, then maybe better to avoid these ones. Generally speaking, I mean, you can go with tablets, right? Tablets would not have gelatin in the capsule. And then other antidepressants do not have gelatin um, in the capsules. Great. Okay. Um, 40-year-old female with depression, neuropathic pain, which to choose? All right, excellent. So duloxetine does have evidence for pain syndromes, right? And is the right choice here. This might be a good time to just discuss a bit about the SNRI class, right? So we've got a few medications there. The ones available in Canada are venlafaxine, desvenlafaxine, duloxetine, and levomilnacipran. So uh, they all have differences in terms of the relative amount of serotonin reuptake inhibition versus norepinephrine reuptake inhibition. So with venlafaxine, it's 30 to 1, so meaning 30 of the serotonin reuptake inhibition to 1 norepinephrine reuptake inhibition. For desvenlafaxine and duloxetine, it's 10 to 1, and for levomilnacipran, it's 1 to 2. So you have more of the norepinephrine reuptake inhibition with the levomilnacipran or Sfitsima. And why this is important is, well, it's good to know what the norepinephrine reuptake inhibition does, right? So norepinephrine reuptake inhibition tends to be a little bit more effective for pain conditions, or if you have fatigue, anergia, low motivation, right? And attentional symptoms as well. That's why there is some evidence for its SNRI use in ADHD, for example, as third line options. And side effects often. There are certain side effects that are more likely as well. So, for example, you're more likely to get hypertension, you're more likely to get tachycardia, sweating, tremor, agitation, insomnia, and then withdrawal effects tend to be worse as well. So keep that in mind when you're thinking about what the right fit might be for someone. Interestingly, though, I did mention that hypertension is more likely with more norepinephrine reuptake inhibition, and I did also say that venlafaxine has less norepinephrine reuptake inhibition than the other SNRIs, but venlafaxine is the most likely to cause hypertension than the other SNRIs, and that's because duloxetine has high protein binding, and the other half-lives are longer for levomilnacipran and duloxetine compared to venlafaxine. Okay, all right. So next one, we have a 25-year-old male with major depressive disorder, ADHD, anergia, amotivation, hypersomnia, also wants to quit smoking. What would you choose? Best choice here. Nice work. Yeah. So the answer here is bupropion because bupropion can do all of these things. For someone who has depression and ADHD comorbidity, bupropion is considered a first-line option for the people who have those two together. And bupropion is really good at targeting the anergia, amotivation, right? The hypersomnia, and also it has evidence for good evidence for smoking cessation. I saw some people picked varenicline, which is Champix, and yes, that also has evidence for smoking cessation, but would not help with the other pieces. Desipramine is a tricyclic antidepressant, and it actually does have some evidence in ADHD and of course depression as well. It does help with anergia, motivation, hypersomnia. I'm not aware of any evidence for smoking cessation, but and also it's not we don't usually go with TCAs as first line because TCAs, generally speaking, do come along with other side effects, with more side effects, and are at a higher risk of fatalities with overdose. Tranylcypromine is a monoamine oxidase inhibitor, which also actually can really target the anergia, motivation, hypersomnia really well, and the depression. But we don't go to monoamine oxidase inhibitors unless we need to. Modafinil would also help with many of those symptoms, and as well as ADHD, but is not indicated for major depressive disorder, although it can be used in augmentation. I'm not aware of any evidence for helping with smoking. And then levomilnacipran, I'm not aware of any evidence for smoking. But, okay. Great. Okay, so 24-year-old male, depression, GAD, generalized anxiety disorder, concerned about the sexual side effects of antidepressants. What would you choose? All right, I think I got a few people here. So, all of these are good choices for the concern about the sexual side effects, right? Bupropion especially is probably the best. It actually it can help with many of them. Um, Even though, by the way, and some of the psychiatrists might be surprised that there's actually RCT evidence does not support bupropion as reversing sexual side effects from the RCTs that have done have been negative. But we've seen from clinical practice it certainly does help. Sometimes we can add on bupropion to antidepressants to help reverse some sexual side effects. Vortioxine, vilazodone tend to have less sexual side effects, although you can still get them, and same with mirtazapine as well. But the reason why mirtazapine and vilazodone are correct here is because of the GAD component. So bupropion is not usually as effective for generalized anxiety disorder. In fact, it can sometimes make anxiety worse. Now, in some people, it can actually make anxiety better, and in those people, it tends to be people who have some executive dysfunction, maybe related to ADHD, and that causes anxiety. And then when that is treated, then the anxiety improves. So that's kind of the theory behind that. But you do want to be cautious when giving bupropion to someone with anxiety. And vortioxetine also has done several studies have been done for anxiety disorder, which have all been negative. So good choice for depression, but not perhaps for anxiety. All right. Okay. 48-year-old male with post-traumatic stress disorder has been on venlafaxine for 2 months. Mood's improved, but the hyperarousal has continued. Nightmares have worsened. He's starting imagery rehearsal therapy. What would be your next step pharmacologically? All right. So this one might be a bit controversial, but the reason why blue may be the correct answer here is that venlafaxine in 7 to 10% of cases can potentially worsen nightmares. And it's thought to be due to the noradrenergic effect. So switching antidepressants might be the right choice here. Uh, why this might be controversial is around the doxazosin piece. So let me talk to you a little bit about this. So prazosin, as we heard, can be effective for PTSD-related nightmares, and prazosin is there is more evidence base supporting that compared to doxazosin. But doxazosin is also, just like prazosin, an alpha-1 adrenergic antagonist and can be used off-label for nightmares and flashbacks and hypervigilance. And there have been less studies, as I mentioned, done for doxazosin, but it does tend to be better tolerated. And from clinical experience, I can share that it's very effective. In contrast to prazosin, its half-life is longer, much longer. It's about 16 to 30 hours, whereas prazosin is about 2 to 3 hours. And due to the better absorption profile, the risk of hypotension is much lower. So that's usually the main issue people have with prazosin is the hypotension. So, and this slower onset of action also reduces the risk of the first dose postural hypotension as compared to prazosin. So in patients I've switched from prazosin to doxazosin, I found that if they suffer from daytime flashbacks, hyperarousal, hypervigilance, these tend to be improved with doxazosin, and I suspect that's due to the longer half-life. So usually you start that at 1 milligram, and then you up titrate it to 4 to 8 milligrams based on tolerability and response. And you want to aim for nightmare eradication, not just amelioration. But you want to pause up titration if they're dizzy or hypotensive. Prazosin BID is also used. So prazosin during the daytime, there is some evidence, weak evidence, but there is some evidence that it can be useful for hypervigilance and hyperarousal and possibly even some flashbacks. Yeah, so I think there may be some comments here because I am very interested to hear if there's any other thoughts. Yes. Right. So that's a good point. So the question is, well, if the mood improved, and the rule of thumb that we discussed earlier was to actually augment, right? Why would we switch? Well, the reason why I would suggest switching here is because venlafaxine may actually be the cause of worsened nightmares. So the nightmares didn't just stay the same; they actually worsened with the venlafaxine increase. Um, but yeah, good question. Like if the situation slightly different or something. Yeah, yeah, and that is the right answer, right? Like these situations, you want to discuss it with the patient. It's not always like straightforward, especially with a one-liner thing here. But are there any other comments here, or? Dr. Howard? No? Okay. All right. Okay. Excellent. So good job, ZF. I know who that is. 25-year-old male, depression, melancholic features, passive suicidal ideation, lots of past major depressive episodes, family history of major depressive disorder, has a partial response to fluoxetine. What is the best next step? So melancholic depression, we have a bit longer here, so don't worry. Melancholic depression is when you really have profound anhedonia, right? And you have lack of reactivity to anything that's pleasurable. And then often it comes along with um, like really low mood and depression that's worse in the morning, and you wake up too early often, and you have a lot of psychomotor retardation, sometimes agitation, and then weight loss, lots of guilt. So that's what melancholic depression looks like. So what would be your this is a profile of someone who would respond really well to one of these augmenting approaches. All right, so the answer here is to add lithium. And I put a profile up of someone who has a textbook definition of someone who responds well to lithium as an augmenting agent. So especially if someone has these features, you'd want to consider augmenting with lithium. If you want if you have more questions about prescribing lithium, happy to discuss that. Also have a handout I can send your way too. Increasing fluoxetine to 80 milligrams. So 60 milligrams is the Health Canada maximum for depression. There are some situations where one would go beyond the top dose, right? Especially in OCD, which often does require beyond the Health Canada maximum doses. Um, uh, uh, tr- Triiodothyronine or Cytomel. So this is an interesting augmenting option. It's a second line augmenting option as well. It wouldn't be my choice here, just given how good of a choice lithium is. But who would be the right profile of someone to give this to? So the right profile of someone would be it tends to be more effective in women, especially women who are a bit or middle-aged or a bit older, and in those with really low energy and motivation, definitely if they have hypothyroidism or if they have subclinical hypothyroidism as well, right? That's a profile of someone who would typically respond really well to T3. So in order to prescribe T3, you would do a baseline TSH, and then you want to recheck thyroid function every 6 to 12 weeks, um, and then earlier if they're symptomatic. And you usually start at 25 micrograms, unless they're like older and more frail, in which case you'd start at 12.5. And you stick with 25 for at least a week, usually 2 weeks. And then, if there's no response or they need more response, you could go up to 50 micrograms. But keep in mind that actually there was research done and showed that there was no difference between 25 micrograms and 50 micrograms. So you want to be very mindful of that if you go up on the dose, and only keep the higher dose if it actually is having more of an effect. So it tends to be pretty well tolerated, but you do get some anxiety, tachycardia, sweating that can happen more with the higher doses. Okay. But that usually improves with dose reduction. So there is some concern in the longer term that osteoporosis could worsen or develop, but that's not shown up in the clinical studies, and it's not really a reason to avoid treatment if depression is significant. Usually you take it in the morning. You don't worry about taking it with regards to meals, since food does not alter absorption. And cariprazine is a antipsychotic that's one of the newer ones. It's a second line augmenting agent. It's useful for especially in bipolar disorder, because it's useful for mania, for depression, bipolar mania, bipolar depression, bipolar mixed features, and yeah. Okay, great. So, okay, Fia is winning now. So, 37-year-old male, escitalopram daily, but has nausea when taken on an empty stomach. Ramadan is approaching. What to recommend? Nice, good work. Yeah. So you want to take it with food, right? Now you don't break your fast with escitalopram. You take the food, you have the food first, and then you have the escitalopram. So often, actually, we tell people to take the medication with food, right? But then they take the medication and then have the food. But no, it helps with the GI side effects of the food first. So you say after food. With ginger ale, one person mentioned with ginger ale. So you know what? Taking it with ginger can be helpful for the nausea, but ginger ale specifically actually has very little ginger. So usually, you can recommend 500 to 1,000 milligrams of dry ginger powder with the medication, or ginger root capsules, right? They're typically about 550 milligrams each. Ginger extract liquid, grated ginger, ginger tea, right? So those things can be helpful. Co-prescribing with omeprazole daily. So omeprazole is useful for, if there's GERD, for example, that's contributing to the nausea, right? It's a PPI. But keep in mind that actually omeprazole can double escitalopram's levels because of an interaction. So does that include questions or before questions? Okay, okay, all right. Okay. Um, all right. So uh great. Okay, and then vilazodone. Yeah, you don't want to switch to vilazodone because vilazodone is the one antidepressant that you absolutely have to have it with food to help with the absorption, and it's also much more likely to cause nausea. All right. Okay. So I'm just gonna. We have a lot more questions, but I think maybe now might be a good time to just pause and see if there's any questions from the rest of the audience that have come in. We can discuss that, and if not, we can continue. And we've got a lot more questions for the next. I think do we have 15 more minutes left, or 10 more minutes? Yeah. Okay. 10 minutes. Okay. Yes. Right. Yeah, so the question was if you have someone who's presenting with depression who you're wondering if they actually might have bipolar disorder, right? And with that, and you're wondering if you could go straight to using like brexpiprazole, or is that okay? Right. Yeah. Yeah, so I have done that in some similar situations, but generally speaking, if it's not criteria for bipolar disorder, you would still start with the depression with the antidepressant, but you would do it cautiously. You would watch them maybe a bit more carefully. You start at a lower dose. You might want to encourage them to speak to their family and, signs of mania, of course, signs of affective switching, and signs of worsening mixed features as well. So that would be the usual approach, and then you would but if the situation's a little bit different, like especially if there's some psychotic or quasi-psychotic features, then I would go with like brexpiprazole or something first. I don't wonder if there's other thoughts on that. But yeah. Okay, all right. Well, if there's no other questions, let's continue with a few more questions. So we've got a 55-year-old male, depression, elevated serum transaminases. What to choose and what would you avoid? All right. Yeah. So escitalopram, desvenlafaxine are generally considered to be relatively safe in this situation. Duloxetine, you typically want to avoid. Okay. All right. 53-year-old female, depression and OCD. Venlafaxine was increased 3 months ago. There's improved obsessions, but ongoing, and then there's still low mood, motivation, energy, and focus. So what would you do next? All right. Okay. So both of these would be quite reasonable options. The reason why bupropion is not on the list here is because with OCD, you really need serotonin. You really need serotonin reuptake, and bupropion actually does not impact serotonin reuptake. And let's talk a little bit about going up beyond the Health Canada maximum of medications, in particular venlafaxine. So, as I mentioned before, going up beyond the Health Canada maximum dose is a common technique in OCD. And in venlafaxine in particular, it's very interesting because while the monograph still recommends the maximum as 225, there's now substantial research supporting further efficacy at higher doses. And in fact, unlike most antidepressant, venlafaxine often continues to show a linear dose response curve without a plateau in effectiveness. Most other antidepressants, they plateau in effectiveness around their maximum dose, but not venlafaxine. So even at doses above 375. Some psychiatrists in California, they go as high as 900 milligrams combined with mirtazapine for difficult to treat depression. Now, I've never been close to that bold, but I'm not suggesting you do that. But venlafaxine, what it does is it prevents the reuptake of serotonin when its dose is under 150, and then it starts to prevent the reuptake of norepinephrine when you go above 150, and then when you go above 300, that's when it starts to work on dopamine and prevent the reuptake there. So the rule to follow is that if there has been evidence of more effectiveness with each dose increase, and it is well tolerated, and further therapeutic effect is needed, then it may be appropriate to optimize further with informed consent. So, if the person is not clearly deriving benefit from the higher dose, then it would be most appropriate to bring it back down to the previous dose. And when you're assessing tolerability at the higher than monograph recommended doses, it's appropriate not only to rely on the patient's subjective report, but also to monitor for side effects with some additional investigation. So, in particular, you want to think about an ECG to rule out QTC prolongation. You want to think about doing electrolytes. Mostly to ensure there's no hyponatremia, although hyponatremia is not really a dose-dependent side effect, but it's kind of more for medical legal reasons. Blood pressure, heart rate, venlafaxine can increase both, as we talked about, and more so at higher doses. And then LFTs are also considered as well. You want to ask about signs of serotonin syndrome. You want to keep an eye out for that, although it's quite unlikely if you just have one serotonergic agent. And then serial assessments to ensure that it is indeed having more of an effect and is being well tolerated. All right, and then aripiprazole, which is a first line intervention. Let me know when we're running low on time. And 2 minutes? Okay, all right. So I think it's enough for one last one before we announce the winner. All right. 80-year-old female, generalized anxiety disorder with migraines on sumatriptan. Which one would you choose? All right. So there's a few tricks here. So first of all, you might have heard that we want to be careful about combining triptans with antidepressants because of the risk of serotonin syndrome. So in 2006, there was actually a black box warning by the FDA on this on this risk if you co-prescribe it. But then there was a subsequent review just 4 years later, and they looked at the cases that informed that decision and found that the modern Hunter criteria for serotonin syndrome was not met in any of those cases that they used to inform their recommendation. So the American Headache Society released a statement saying that the currently available evidence does not support limiting the use of triptans with SSRIs or SNRIs due to concerns for serotonin syndrome. I mean, it is something that one wants to sort of be maybe a little bit more cautious around and and warn them about it and monitor for it for sure. But it's not a contraindication. The reason why amitriptyline is not the correct answer here is because of the age, 80-year-old female. We typically don't want to use tricyclic antidepressants as a first-line intervention for people of this age group. Similarly, fluoxetine has a long half-life and usually is not the best choice in geriatrics. But amitriptyline does have good evidence for migraine relief, better evidence than desvenlafaxine does, although desvenlafaxine does have some evidence as well. Um, and yeah, there's a comment here, I think. Yeah. Or okay, all right. Right. Well, yeah, definitely. I mean, these are very small clinical things, right? I mean, usually in these situations, of course, you want to do a proper workup, everything, right? And yeah. Um, all right. Okay. So it was a pleasure to be with all of you today. As I mentioned, you can email me. It's ayaz.kurji@psychiatry-on-call.com, and I'm happy to send you resources and the handouts that are relevant to the ones that we discussed. And thanks for all the participation and discussion and for having me here today. Oh, and the winner is our psychiatrist, Zainab. Congratulations. Great. Awesome.